Thanks, Michael. It's really great to see this kind of turnout for what's going to be a great event going forward. Before I launch in, can I just get a quick show of hands? How many of you are undergraduate global health majors minors? Masters of Science students? Good representation. Doctoral students? Not many. Postdocs? Handful of staff? Faculty? Did I miss any categories? Thanks. I just wanted to get a sense of the room. So several months ago, I gave a talk to kind of introduce myself to DGHI. It was a smaller group. I touched on some of the themes that I'll be talking about today, but we thought this global health, this Think Global seminar would be a good opportunity for me to do a deeper dive into our work and talk about this, the work we're doing in Myanmar that we can refer to as global health diplomacy. In part because it may be an approach that will have value elsewhere in DGHI and at other partner locations. And I don't typically kind of go off notes when I give a talk, but I will this time because this is not, these are not things that I talk about day in and day out for years and years. But nevertheless, please feel free to ask questions or raise your hand as we go. And we should have time at the end also for some questions and discussion. So in global health, our vision is of a world where there is social justice and health equity for all. Each of us, each of you sitting here today, is working hard every day to make the world a better and a healthier place. And whether you're earning your master's degree in global health or developing an mHealth app or catching mosquitoes in Kenya, as we just recently did, or studying health systems in China, the spirit that animates your work is one of beneficence, justice, generosity, and peace. But we don't live in a beneficent and peaceful world. Right now, there are no fewer than 58 wars being waged worldwide. You can see the distribution as of last month. I don't know about you, but I sometimes find I just kind of feel exhausted by the constant drumbeat of grim news about war and brutality and suffering. And so as global health professionals and learners, how do we see ourselves in our work in relation to war and violence? Do we try to just set aside these disturbing images that we're constantly bombarded with and continue to do our small part to make the world a little better, just putting one foot in front of the other each day and hoping our collective efforts will someday win out against the forces of death and destruction? And maybe as individuals we do, and maybe we should sometimes turn our attention away from all the bad news and focus on the good that we can do in our work and in our communities and in our families. But as a global health community, historically we also have a long history of responding to the demands of wartime by making discoveries, developing new treatments and health interventions, and creating new institutions that ultimately improve global health in important and lasting ways. The connection between wars and global health problems is obvious when you look at the map of the world, whether, as you're seeing here, the distribution of malaria around the world, or cervical cancer, or malnutrition. You could use any number of global health issues to make this point. There's simply more war in the less economically developed countries. There's more disease, and of course, far less capable health systems in war zones and conflict areas. And this is true not just at the global level, but at the local level as well, including here in this country, in the US, where in our poorer counties and neighborhoods, social discord and conflict go hand in hand with health disparity. I'm going to tell you about a few historical examples of how we, by we I mean the global health community, have transformed the destructive forces of war between humans into new treatments and capabilities that ultimately improve global health. And then I'll tell you about some of my experiences that have led me to ask whether we can turn this equation around, examples of how our work in global health can serve as a means of promoting peace. It's well understood that war and conflict inflict a terrible burden on health. The term global health diplomacy has been used to describe how this dynamic can be turned around in the sense that that recognition of common suffering can promote cooperation on health problems. And I'll give you an example or two of this in a minute. But I'd really like you to think about is whether there is a potential to take this even further In other words, can commonly shared global health interests be used to foster political and social reconciliation? Put most simply, can global health be a catalyst for peace? In thinking about the relationship between war and global health, it's worth remembering that some of our leading public health and research institutions were created in response to and shaped by our war efforts. The Malaria Control and War Areas, MCWA, was established in 1942 to combat malaria around military training bases within the US, and then after the war, the MCWA became the CDC. And so in thinking about the relationship, and the National Institutes of Health creation story goes back even further to 1887, where a one-room laboratory was set up at the Marine Hospital on Staten Island to monitor returning merchant seamen and hoping to prevent epidemics of cholera and yellow fever. And in 1912, the Marine Hospital Service became the Public Health Service, and that small laboratory became the National Institute of Health, with no S after institute, in 1930. And then NIH expanded dramatically during World War II, in large part to develop vaccines for tropical diseases like typhus and yellow fever. They were causing heavy troop casualties, but especially it was created to make synthetic new anti-malarial drugs. In another example, during the Second World War, in parallel with the race to build a nuclear bomb, German and American scientists were also in a race to find a new drug for malaria after the Japanese took control of the world's supply of quinine, which is then really the only anti-malarial drug. The Japanese took control of that supply by occupying Indonesia, where 97% of the world's quinine was produced. That race led to the development of chloroquine, which saved countless lives during the second half of the 20th century. Another pharmaceutical arms race took place during the Vietnam War, when North Vietnamese troops started dying in large numbers along the Ho Chi Minh Trail, not from American bombs, but from chloroquine-resistant malaria. The North Vietnamese turned to China for help. This was during Chairman Mao's, that's Chairman Mao in the middle, during Chairman Mao's Cultural Revolution, when most intellectuals, including most scientists, were being shipped off to re-education camps. But malariologists, Chinese malariologists, were spared from the camps and were tasked with finding a replacement drug for chloroquine. They went through ancient records of traditional herbal treatments, and they found records of the plant Qinghao Su, which had been used for at least 2,000 years to treat intermittent fevers. In work that was recognized just a couple of years ago by a Nobel Prize, Dr. Tu Yu, pictured on the right, and her colleagues developed the artemisinins, which are now used to treat malaria worldwide. So I think we can see that while war, of course, has absolutely devastating negative consequences for health, there's also almost a perverse calculus in which we might say that war has been good for global health, in the sense that war and conflict have indirectly led, again and again, to life-saving new treatments and institutions that ultimately may end up saving as many or more lives than those lost in wars. And so the case I want to make to you today is that the impact can go in the other direction. Yes, war and conflict impact on health in different ways, many negative, also some positive. But I'd like to convince you that global health can in turn become a force for social and political reconciliation and for peace. And so in thinking about how we as individuals and as global health professionals respond to violence and war, I go back to my own childhood in South Dakota, where my dad was an Episcopal priest, ministering to the Lakota Indian people on the Pine Ridge and Rosebud reservations in the kind of southwestern corner of the state. And so here you can see the teepees in the background behind my parents at the Niobrara Convocation, which is an annual meeting of the reservation churches that they still have. And the reservation, of course, has always been a violent place. Just 40 miles from the little town of Martin, South Dakota, where I grew up, in 1890, the U.S. 7th Cavalry massacred 200 Lakota, mostly old men, women, and children, at Wounded Knee on the Pine Ridge Reservation. And then when I was in junior high school, a group of 200 Lakota occupied that same town of Wounded Knee to protest corruption and abuse on the reservation. U.S. Marshals and the FBI moved in, the shooting started, there were deaths on both sides before the tribal elders called an end to the protest after more than 2 months of fighting. So this was the background of my childhood. And in fact, I just very recently realized that my My first introduction to the idea of health disparity was when I lived in Martin, that little town in South Dakota, where one day when I was in, I think it was probably 4th or 5th grade, as I headed out to walk to school one day, I looked at the front door and there was blood spattered up and down the door. It looked like arterial blood, as a matter of fact. And it turned out that a Lakota man had been injured in a fight the night before in Martin, and he came to our house for help because the local hospital refused to treat Native Americans. And so my dad had to drive him to the hospital in Pine Ridge, an hour away. And I personally experienced violence on more than one occasion, including I got pretty badly beaten up at the age of 13 by 4 older high school boys. They thought I was throwing snowballs at their car. In fact, I was throwing snowballs at somebody else's car. I wasn't throwing snowballs at their car. But I got beaten down. I got kicked in the face, and my response to that was to carry a great big folding knife in my back pocket all through the rest of junior high and high school. I took it to school every day, if you can believe that. It was a pretty different time. But that's a natural response to violence, to arm yourself, maybe even to form a militia, to occupy something and prepare to fight back. And I know someone else who had the same very understandable response to violence, at least initially. So this is a photo of 4 fifth-year medical students at Rangoon University in Myanmar, the Southeast Asian country formerly known as Burma. Some of you might recognize the one on the left, one with the trench coat over her traditional longi, and I'll come back to her in just a minute. But these students' lives were shattered just a few months after that photo was taken by a violent uprising in Burma. Students, including medical students, were at the forefront of a national protest against the ruling military regime. The students actually briefly seemed to carry the day. They were kind of in charge of the country for a short period of time. And they convinced a young professor, Aung San Suu Kyi, shown here on the right, giving her first public speech, surrounded by the student activists. They convinced her to be their leader. But that kind of heady moment didn't last. The protests were brutally put down by the military government. Peacefully protesting nurses and students were gunned down in the streets. Thousands were killed, many students, many more were imprisoned, and others went into exile. Large numbers of Burmese students congregated on the border between Myanmar and Burma and Thailand, where they linked up with some of the ethnic armies that had been fighting against the military government for independence for decades, long before this uprising started. The students joined them, and the students had a very understandable response to the violence that had been inflicted on them. They armed themselves, and they tried to raise an army to go back and take on the Burmese military. The student on the left in this photograph, holding a gun, is the same one you saw wearing a trench coat over her laundry in the earlier photo. The students' plans to fight didn't get very far. The military government of Burma stayed in power. It became increasingly isolated and xenophobic. Economic sanctions were imposed by the US and other Western countries, and that only increased the isolation in the country. Most of the students eventually gave up the fight, scattered to the winds, and tried to rebuild their lives. And our young medical student, pictured above, lived briefly in Thailand as an illegal immigrant and then sought asylum in England before coming to the US, where she started her medical training all over again, having been a fifth-year medical student in Myanmar. And eventually she became a malariologist. For many years, she was unable to go back home to Burma, which is now called Myanmar. She was blacklisted by the government, and she would have gone from the airport straight to prison had she gone back. She remained bitterly opposed to any kind of engagement with the Myanmar government, and she fully supported the sanctions. And there was another major anti-government uprising in Myanmar in 2007. This time led not by students, but by Burmese monks, who are very highly respected and revered in Burmese society. This time the whole world was watching, but despite the international attention, the government's response was the same. There were more guns, more violence, more deaths. And our former young student was really distressed and dismayed by this. She and her fellow members of this 88 generation of student leaders had always believed that if only the rest of the world, and especially the US, had known what was happening in 1988, they would have intervened. And so after seeing the Saffron Revolution end the same way that the 88 uprising did, and this time, despite the whole world watching it unfold on the internet and doing nothing to help, our former student rebels' thinking changed. Raising an army to fight back was futile. Decades of sanctions had had minimal effect, and so maybe it was time to take a different approach. So by this time, our one-time rebel, whom you maybe have figured out is DGHI faculty member Myeng Myeng Nyun. By then she was married to and working with another malaria researcher. And together, the two of us decided to reach out to our fellow malariologists inside Myanmar. Slowly, initially, and quietly, in 2009, we began collaborating with both civilian and military government malaria researchers. At our first meeting, we actually met with someone from essentially the Burmese NIH, and we had to meet in a restaurant on a Sunday when the restaurant was closed and open just for us, and we kind of had to sit behind some bushes because people really, you couldn't be seen meeting with a foreigner without potentially getting in big trouble. And we chose to work with the Burmese government, including the military, despite its terrible record of human rights abuses for several reasons. First, many of the places in Myanmar with the most malaria are in conflict areas that only the military can reach. And we simply can't make real progress against malaria in Myanmar without working with the military along with the Ministry of Health and the private sector. And we found that there were some very well-trained and dedicated military doctors and scientists working on malaria who shared the motivation we all have to improve the health of the people of Myanmar and the region. And finally, by engaging the military and medical corps, we hope to begin building links between the military and other groups within Myanmar who have been working in complete isolation from each other. We were, as you see in this picture, we were the first foreign visitors to the Defense Services Medical Research Center in the hills outside of the capital, Naypyidaw, in 2011. And so here you have the formal rebel not only shaking hands with uniformed Burmese military officers, but now working with, shown here, Brigadier General Dr. Tin Mao Lang, a malaria epidemiologist, and his team to conduct molecular surveillance in support of malaria elimination. So not long after we started working in Myanmar, things began to change at the political level. Aung San Suu Kyi was released from almost 20 years of house arrest in 2010, and the military government transferred power to a nominally civilian government, although they really, to this day, still retain most of the control over the government. And in 2012, the U.S. resumed full diplomatic relations with Myanmar, and by the next year, both Secretary of State Clinton and President Obama visited and met with the president, shown on the left, and Aung San Suu Kyi on the right. And this thawing of relations made it possible for us to get the first ever NIH grant to work inside Myanmar with Myanmar government scientists. That was in 2014, I think. And so that grant gave us an opening to organize training in ethics for our collaborators, including the military. In order to get U.S., you probably know this, in order to get U.S. federal funding for human subjects research, institutions have to have an ethical review committee, or IRB, and the IRB has to apply for what's called a federal-wide assurance from the Office of Human Research Protections in the Department of Health and Human Services, basically certifying that their IRB meets criteria that are meant to assure protection of human research subjects, which amounts more or less to a license to do human research. Anywhere in the world you're working, if you're getting U.S. federal funds, you have to have this federal-wide assurance. And one important way of building political will for malaria elimination, we believe, is to build local capacity for malaria research and surveillance. So part of Myeng's vision has been to use malaria research as a way to start conversations in Myanmar about things like ethics as well as professionalism. With support from the Fogarty International Center, she organized training workshops in research ethics and helped both the civilian and the military IRBs get their federal-wide assurances. And despite the importance of human rights issues in Myanmar, at that time overtly using human rights as a framework for discussion, as we started working there, it just wasn't possible. People wouldn't and couldn't openly talk about human rights. But what is the protection of human subjects and informed consent if not human rights? And so here we have the former rebel now training soldiers in ethics and essentially in human rights. So Myeng was able to convince George Soros through his Open Society Foundations to support training in clinical ethics and professionalism for medical students. One of her early Open Society projects was called Malaria as a Catalyst for Social Change. Myeng's idea was to use a shared goal of combating malaria to build new trust and cooperation between diverse groups in Myanmar, including not just civilian and military malaria workers in the government, but also community-based organizations who were linked with the ethnic militias in the border areas who had long histories of conflict with the government. These were groups that had no direct communication with the government, couldn't travel in the country, and so forth. But malaria affects everybody, as other global health problems do. In this case, soldiers, rebels, farmers, gold miners, rubber plantation workers, especially in the remote border conflict areas. And even if the government and border groups can't reach political agreement, surely we hoped they could agree to eliminate malaria. And maybe starting a conversation and getting agreement about shared health goals like malaria elimination could help establish the beginning of trust and understanding where there was not at all before. And of course, there have been other examples of using shared health goals to foster peace, at least for a little while. In El Salvador, Sri Lanka, Afghanistan, lots of other countries, warring parties have agreed to temporary ceasefires in order to allow people on both sides to be vaccinated against smallpox, polio, childhood diseases. But these so-called days of tranquility are only temporary. One day the shooting stops so vaccination teams can come in and do their work, and then the next day shooting resumes again. So our hope is that we can use shared health goals to pursue more lasting peace. In 2014, Bill Gates was our keynote speaker at the annual meeting of the American Society of Tropical Medicine and Hygiene. He'd been invited by our outgoing president, shown, and Bill Gates is right there, Ellen McGill, who was then the director of the malaria program at the Gates Foundation. And Yang and I had also invited the Myanmar National Malaria Control Program Manager and director of the equivalent of NIH in Myanmar, these two gentlemen here, to the same meeting. They were very happy to get to meet Mr. Gates. This is the council meeting, the STMH council meeting that year. And later during the same meeting, we sat down with Alan and our two Myanmar colleagues and had a very interesting discussion. Even though Myanmar had and still has the most malaria of any country in Southeast Asia and lots of challenges to overcome, we talked about whether it was possible that Myanmar could make a decision to not be the last, but to actually be the first country in the region to eliminate malaria. And shortly before that ASTMH meeting, Alan had visited Myanmar for the first time, and he came away very impressed by the quality and the commitment of diverse members of the malaria community that he met, not only from the government, but also from the private sector and NGOs, non-governmental organizations. Most of those organizations had limited interaction with the Ministry of Health and none at all with the military, but Alan could see the potential for cross-sectoral cooperation as Myanmar began to open up. And so Alan's specific suggestion to our Myanmar visitors was, could malaria elimination serve as a national reconciliation campaign in Myanmar, much like Nelson Mandela made winning the World Cup a national goal to help reconcile post-apartheid South Africa? And so the next month in Myanmar, we brought together civilian and military, public and private partners to work on a protocol for malaria surveillance for our Gates project that was starting. So here you can see on the left a leading Ministry of Health malaria expert. Next to him, a young country director, a Burmese doctor who was directing an NGO that had worked for many years along the border with Thailand from the Thai side. And he and his colleagues have been really persona non grata inside the country until quite recently. And then next to him, our malariologist colleague, the Brigadier General, and then the former rebel on the right there, all having lunch together and sharing a laugh. And this kind of a scene just a couple years earlier would have been completely inconceivable. So the protocol we were working on at that meeting was for malaria surveillance using a new ultrasensitive molecular test that we developed for detecting asymptomatic malaria infections. And we worked both with the civilian and the military malaria researchers to set up labs, two labs, one civilian, one military, to perform these tests. And we've used them in close partnership with our Myanmar colleagues, both for our research studies as well as in support of national malaria elimination. We perform these tests all over the country as part of the National Malaria Survey. And this malaria mapping project included partners from the Ministry of Health, Ministry of Defense, several NGOs that work in border areas that the government can't access. Another partner is the Chinese CDC and their National Institute of Parasitic Diseases, who are uniquely able to get into certain areas in Kachin and Shan states along the China-Myanmar border that the government inside can't reach. The study that I'm showing here is in, I think it's the pointer, this little tongue of Myanmar sticking down next to Thailand, Thanathiri region, and we mapped malaria in 35 villages with this test and found that even though the standard rapid diagnostic test that you use to detect malaria found only 2 positive infections in 1,750 people in 50 villages, we had 9 positive villages by the molecular test with prevalences up to around 20%. This was actually used to target 3 of the highest prevalence villages for mass drug administration. So this kind of partnership with all sectors is critical precisely because malaria remains the most prevalent in exactly the same remote border areas where conflict and fighting continues to happen. Our current projects, which are supported by an International Center of Excellence for Malaria Research grant from NIH, and grants that Myang holds from the Gates Foundation and the US President's Malaria Initiative, among others, includes an assessment of a new highly sensitive rapid diagnostic test that's a point-of-care test, so not like the molecular test where we have to take the samples back to the lab, but basically a new, more sensitive version of the kind of testing you can do directly out in the village. And so Myang and her team are doing an assessment of this new test in Rakhine State, and we're planning a cluster randomized trial of mass drug administration versus a screen and treat strategy with this test in Mandalay region. And again, these projects involve capacity strengthening and partnership with both the government and several NGOs, some of whom were closely associated with the ethnic militias, who had and still have long adversarial histories with the government. And this research work has had an impact on regional health policy. In just one example, we used genomic epidemiology approaches to show that artemisinin-resistant malaria was not just spreading from where it first started out in Western Cambodia here. The thinking was this was spreading contiguously from a single point of origin, partly because that's what happened with at least 3, if not 4, other malaria drugs to which the parasites became resistant. And what our results showed, I won't explain that map to you unless you want to come see me and go through it in detail. But what it showed was that it was emerging independently in Myanmar and in other parts around the region, as well as spreading from one country to another. We shared these results in real time with the National Malaria Control Program, as well as with the WHO. And ultimately, that observation led to a recommendation by the WHO, which was taken up by all the countries in the region, to abandon an initial strategy of trying to contain the spread of resistance by very focused control efforts, essentially trying to put up a firewall along the Thailand-Myanmar border. It was popping up on either side of the borders. That strategy we felt didn't make sense. So the WHO recommended and countries agreed to launch a regional malaria elimination campaign in all the countries in that region. And that's underway now. And so in parallel with these research studies, we took the malaria diplomacy approach to another level, together with the ASTMH and the Center for Strategic and International Studies, which is a bipartisan think tank in Washington, D.C. We organized a conference on malaria elimination in Myanmar. The conference was in D.C. It was on malaria elimination in Myanmar. The goal was to bring together a diverse group of partners from Myanmar, many of whom had this history of adversarial relationships with the government and who had never sat down before together to talk about anything and try to get them to agree to work together to eliminate malaria from Myanmar. So we were told that this would never work, that the opposition politicians would never agree to sit down with the government, that the ethnic health organizations would have nothing to do with the military, who were, treating their populations terribly, that the State Department here in the U.S. would never approve visas for high-ranking military officers above the rank of colonel to travel to the U.S. Well, the event did happen. It was a success. The Deputy Minister of Health, the senior advisor to the President of Myanmar, members of Parliament, both from the ruling military party and the then opposition party, Aung San Suu Kyi's National League for Democracy, Suu Kyi's senior political advisor, who's now leading the peace negotiations with the ethnic groups, as well as 2 brigadier generals from the Myanmar Military Medical Services, and 4 leaders of ethnic health organizations from the conflict areas on the border. All these people were able to travel to Washington for this conference, and they were joined by leaders from the U.S. President's Malaria Initiative, Gates Foundation, the World Bank, the Asia Pacific Leaders Malaria Alliance, and the U.S. military. And WHO and the Global Fund sent statements of support. It was a little tense at first, I will admit, especially on the first day, but over the course of 2 days, we saw new understanding and trust begin to blossom between these former adversaries. And by the end of the second day, we heard very open and frank exchanges in this closed-door meeting. And we saw an amazing coming together of all partners to agree to work together on a national malaria elimination campaign. And so on the bottom right, you can see a photograph from, as the meeting ended, there was a press conference that presented a unanimous consensus that malaria elimination was too important and too urgent to wait for political developments like fully free and fair elections or a national ceasefire, because previously we'd kind of heard that, well, we'd like to work with them, but we have to wait for a ceasefire to be negotiated first. But that malaria elimination should proceed no matter which way the political winds were blowing, either in Myanmar or, for that matter, here in the US. And so in this picture of the press conference, you can see the senior leader of the Karen Ethnic Health Organization, the Deputy Minister of Health from the then ruling military party, the senior political leader from the main opposition party, and Brigadier General from the Myanmar military. And it was really extraordinary to have these 4 people sitting together in a public press conference like this and agreeing to work together. The meeting was widely covered by the media, both here and in Myanmar and in the region. And as a direct result of the meeting, both the Myanmar military as well as the ethnic health organizations have become directly engaged with the Ministry of Health in working toward malaria elimination. The impact of this global health diplomacy work has been modest, but it's been real. For example, we helped to organize a meeting not too long ago to review data on mass drug administration that was hosted by the Ministry of Health, but had sessions chaired by a military malaria expert and included, really for the first time, members of the ethnic health organizations who are attached to these armed militias who are still now negotiating peace agreements with the government. That was really unusual to have these people sitting around and just exchanging data openly and trying to work together to make policy. So I think we can say with some confidence that our global health work has had a meaningful, positive impact on political relationships in this emerging democracy. Health is an area where adversarial partners can agree when they can agree on little else, and it gives everybody an opportunity to take shared credit for doing something good for their people. To do this kind of work, we have to get out of our comfort zones as educators and researchers and reach out to new kinds of partners. For example, Myang and I work closely with CSIS, the Center for Strategic and International Studies, the DC think tank, on our work in Myanmar. And Myang's early work in this area was supported by the Open Society, as I mentioned, which is really not a typical funder for the kind of health work that we do. In fact, one of the real attractions for us coming to DGHI last year was the incredibly diverse cross-disciplinary nature of DGHI, with people working on global health issues just across the board, health policy, health systems, things that are outside of our comfort zones, but that are going to be essential if we're going to achieve big goals in global health like malaria eradication. So going forward, I hope that we can brainstorm together about other areas where this kind of approach has potential. And just one example, I met recently with David Eagle, who's here, who's been working on mental health and clergy in the Democratic Republic of the Congo. Certainly there's plenty of room for diplomacy in places like DRC and in many other places where we work, including right here in North Carolina. And I believe that as a leading global health organization with talented faculty and students from all across Duke University, DGHI is well positioned to lead the way in global health diplomacy. And by the way, this term, global health diplomacy, has been used to refer to the use of health aid to achieve foreign policy aims of a government, basically the idea that if we do something nice for you, you'll do what we want. But that's not what we mean here. We're talking about global health diplomacy in the sense that we've used it in our work in Myanmar, using shared health goals and values to help create new trust and lines of communication between people and organizations that have histories of conflict, using global health to help move toward political and social reconciliation. And so I'll end by putting in a plug for an event next week when Myang will have a discussion with Suzanne Shanahan, the director of the Keenan Institute, specifically about the ethical aspects of doing this kind of work in a place like Myanmar, which continues to have very serious human rights problems. And I hope we can extend this discussion to other troubled countries, and again, maybe including right here in our own country, where there's the potential to use global health to promote social and political reconciliation. And so I'd be happy to take any questions or comments. Thank you.